1700 open screens. All right, so you guys can see the main screen, right?
Yes.
Okay, cool. Yes. All right. So why are we here today? Okay, so we're going to learn about, obviously, and understand the importance of the changes that are coming October 1st. So what's happening to our lovely little code set? You're going to see how the most common home health codes are affected by the changes and what we need to look for. We, as our coders, need to be on the lookout for from the September to October transitions. So again, look for your resumptions of care. Look for your research, anything that was started before September that's now, coming around again. Are there a lot of changes? And when are they effective? That's always like one of the biggest questions. So with all this is also known as, is Walmart still hiring? Okay, Walmart will always be hiring, not to be a cashier, because we know that they're getting rid of a lot of those. Now you just go do it yourself. But yeah, Walmart's always hiring. So there's not a lot of changes, but there's some really good ones. And that's the ones we're going to go to, the ones that are really pertinent to us on a just about daily basis. Parkinson's and osteoporosis got a boost in their codes. So when do we have to know this for? Everyone's like, well, October 1st, but what does that mean? It means it's for your claims dates that are effective October 1 and later. So if it was a start of care on September 30th, this does not apply, right? Starts of care October 1. And again, any claim October 1 and later. So look at your research as well. So when you're working on, right, rocks and research, anything that has spanned over that September 30th to October 1st transition time there, some of these codes are going to require new characters, because the codes, when they finally submit for billing, which is when someone is discharged or transferred in, just, disappears into the ether. Sorry, just got feedback there. Or they disappear into the ether, they submit their claims based on the data that's in there at time of discharge. So the coding has to be correct at the time of discharge, which means, again, anything that spanned over into October 1, the codes have to reflect the October 1 and later code set. So we're going to be looking for our Parkinson's to see if they need new characters. We're going to be looking for the osteoporosis, see if they need new characters. Hopefully the scrubbers are going to bounce these back, say, hey, we need some work done here. But of course, the scrubbers are only as good as the humans that input their systems and got their alerts to run. So we know how much fun they have been in the past. So just stay alert. Parkinson's, that's our first one we're going to hit up here. We all know our Parkinson's default code, G20, right? Bam, we know that. All right, not anymore. They have added more language into it. So when we look at the Parkinson's section that's coming up, we see G20, A1, A2, B1, B2, and AC. So what's this all about? Now they have language of Parkinson's disease without dyskinesia, without mention of fluctuations. You're like, ooh, those are new words. Sometimes you might see that in documentation, especially anything recent now, maybe not. But if you see that documentation coming up, and again, if you're seeing it in the rocks and research, that's a code that you're probably going to have to update if it was coded before September 30th, because we didn't have this language. So that's the ones where we're going to have to update those. And that G20C is Parkinsonism unspecified. Big distinction here. So now they have, they're using this language of dyskinesia. We know tremors, right? We know Parkinson's tremors. Like, is that the same thing? No, it is not. Parkinson's tremor and dyskinesia are two kinds of uncontrollable movements that affect some people, not all, with Parkinson's disease. Tremors, yeah, especially when you get the pill rolling, especially, usually the right hand does a lot of pill rolling. The main differences between the Parkinson's tremor and dyskinesia are that tremor is rhythmic in its movement, usually around one joint, typically the hand. Dyskinesia is not only involuntary, but it's also disordered, could be coming from anywhere. The tremor that's associated with Parkinson's is usually suppressible with movement and activity, while dyskinesia isn't, which means if someone has a tremor in the right hand and you ask them to reach out and touch you, that tremor will typically stop. as opposed to dyskinesia, where if they're having some jerking movement going on with the right hand, you have them reach out to you, they're still going to be jerking and moving with that right hand. Everyone put themselves on mute, please. Both tremor and dyskinesia cause your body to move in ways that you don't want it to, but each have unique causes and produce different types of movements. They also talk about in the descriptions now for these codes, off times. What does that mean? On and obviously off times then. Off times occur when levodopa, which is typically, Sinemet, which is typically what you give someone with Parkinson's, when it's no longer providing any benefits to the patient. So what they do is they take the patient off the medicine. They give them what they call a vacation or a holiday from it. And that is your off time until, they let the body just kind of settle down again. And then they try and reintroduce the medication to see if it can then start helping again. So it's a unique, if you ever saw the movie Awakenings, you would know exactly what that means with the on and off time. And that other box just talks about more about dyskinesia. Now, the thing about dyskinesia is the provider has to use that language, has to use that word dyskinesia, all right, in order for you to code to the dyskinesia. Otherwise, tremors are tremors, which we know is a symptom of Parkinson's, but dyskinesia is something that has to be stated by your provider. So back to the Parkinson's disease grid, such that it works. So I have it spaced out here. So we're like, well, what is our default when the provider doesn't give us anything, which is typical, right? Our default is now G20.A1. And as you can see, Parkinson's disease, NOS, not otherwise specified. The difference is if you go down to G20.C, Parkinsonism, unspecified, has, as it excludes one, Parkinson's disease, which is just a reminder to say, no, not here. You belong back at G20A1. Okay, so that Parkinsonism has all those excludes to it. Just to remind you that Parkinson's and Parkinsonism are not exactly the same thing. And you can see all those Parkinson's disease things talk about either with or without dyskinesia, with or without any mention of fluctuations. So there's just more stuff for us to be aware of, as opposed to just our G20 hit and run when we're doing Parkinson's charts. Now here's a problem, and I already sent this into Decision Health just to see if they had any more insight, and basically they said the same thing as me. What? So I was noticing in the new alpha, because we can see the 2024 code set if we so desire when we look it up. So I looked up, Parkinson's, just Parkinson's, and as you can see in the alpha search, I just typed in Parkinson. And it comes up, you have Parkinson's disease, symptom or tremor, and it says C, Parkinsonism. Oh, well, okay, well, that's interesting. And off to the right, C Parkinsonism has all those G20.Cs and all those G21s. Okay, Parkinsonism, that makes sense. But then when you go down further back on the alphabet, it has disease, Parkinson's, and now we have the G20A1s. I'm like, oh, wait a minute, what's the difference between Parkinson's disease and disease Parkinson's? And that's where I got the deer in the headlights response of, yeah, we have no idea what they're talking about. So you can be assured that if this doesn't get settled out, and again, this is not a Decision Health choice of, we'll make the language clear. They can only do what WHO has dictated by the code set. If it still comes up, ultimately, this is the way the alpha is going to look. We will have an email going out about this, clarification and red flag, and be sure you're on the lookout. And of course, in the tabular, any user notes or group notes we'll have in there just to be sure that you're also correct where you are, that you're in Parkinson's, not Parkinsonism, and vice versa. So it's just, again, I'm still trying to find someone to explain to me in small words what the difference is between Parkinson's disease and disease Parkinson's. Yeah, so just one of those little glitches. Hypertension. No, they didn't mess with it a lot. They just added another category of I1A, other hypertension. So you might see it listed as resistant hypertension. And so what that means is it's poorly responsive to treatment and requires use of multiple meds to achieve acceptable blood pressure ranges. It could be the result of primary or secondary hypertension. So what it includes is apparent treatment resistant hypertension or true resistant hypertension. And it will have a code first note of the type of specific existing hypertension, such as your essential, which is, pretty much our bread and butter, or secondary hypertension, where it's hypertension due to something else. So this code I1A would not stand alone. You would have your I10, we'll just say for kicks and giggles, followed by the I1A.0 code. I can't recall ever seeing this, but I can't recall if I've ever had to think about what does that mean to be.
We would be looking for that language. We would not assume just because we read a note and they've had multiple changes.
Exactly. Good point. That is, again, just like a dyskinesia. We cannot assume that this is what they mean, that it would have to say that it is resistant hypertension. SVTs, currently, if you look under I-47.1 SVT in the tabular, it has clarifying terms of all these different terms here. Well, moving day, they are moving all those clarifying terms and putting them under a new code of I-47.19 for other supraventricular tachycardia. So basically the I-47.1 is just kind of staying in and of itself, just its own little code. All these others are going to obviously an other code set. So it's just moving day. And I just put that because some people, for whatever reason, are just really familiar with this code, and all those that come under it. I'm not one of those. When it comes to the cardiac, it's like Groundhog Day for me. I almost have to look up hypertension every day. I can't keep those cardiacs in my head. Probably because I just hate teaching cardio. COPD. We have some stuff changing here. So we have a new code under the J44 category of J4489, which is other specified chronic obstructive pulmonary disease. And your clarifying term of your chronic asthmatic or obstructive bronchitis and chronic emphysemaceous bronchitis. And has the alpha index changes. So under the chronic J42, we have all these that I have highlighted in the blue there are all going to this new code of J4489. Right now, they were J44.9. All right, so we have some changes coming in there to all these J44.89s. So again, it's kind of moving day again. We're moving things, things that are others into true other codes. Other index changes we have is disease lung, the obstructive 44.9 with bronchitis, again, throwing it into that new code, the J44.89. With dyspnea, asthmatic is now talking about whether it's with bronchitis or chronic, it's just staying at the J45.909. Pneumonia, just get a little clarification for something that has gram-negative bacteria of a J15.6. Again, we're getting another character here for the J15.69. And you can see down under the subcategories, the J15.69 is pneumonia due to other gram-negative bacteria such as aerobic or Serratia something. All right, so it's just more clarification of what other type of gram-negative bacteria might you be talking about. And again, just getting that 9 out there for your true others. We don't know what else to call it. We're just throwing it there. All right, so osteoporosis, we got some good stuff added as well. And
Harlan, can you hear me?
Yeah.
Can you hear me? Before we move from respiratory, there was, and I could be wrong. I am very frequently wrong,
right.
But there not updated guidance if we have emphysema and we have a specified type of COPD, we would now code both of those?
That sounds good. I will have to look that up and I will get that out.
Okay. Look at that and see, because I'm thinking based on
I might have
another
right
meeting I
past
was
it.
on, that was what it was. Because I hate respiratory anyway.
Yeah.
And I have to read every little tiny
So is
tip.
emphysema and a what?
And a specified type of COPD.
April, you're right. It is. It's supposed to be together now. Like you're supposed to
So
code the
code both.
J44 as well.
Okay, I will,
But that
look
would,
that up,
that's only if it's a
investigate it, get a
specified
slide on
type,
it
correct?
and get it out.
Yeah. All right.
All right, excellent. Yes, and I'm due to, probably on Monday, I'll probably get another issue of, that stuff that I've been sending out. Man, I tell you, this is me off caffeine. What the heck do I send that stuff out? The teachable moments. So I'll put that in there. So everyone will see it, regardless of whether or not they were on this call. Okay, so, yeah, here's one of those, like, see my box, for the love of Pete, why? So we actually now have a difference in codes for fracturing the pelvis on pathological fractures versus fracturing the pubis ramus, which is interesting because the pubis ramus is part of the pelvis. Yeah, like I said, for the love of Pete, why? So I even put up a picture. It's like, look, that pink is part of the whole kit and caboodle there, but okay, they want to separate them out. They're more than entitled to do what they want. So I put in here was just volley alpha. Don't think, well, this part of the pelvis, I'm just going to go with pelvis. Now, if you know a more specific bone, follow it in the alpha. So for the pelvis, we have the M80.0B, which is age related. And again, I just use age related as example. If you actually have different type of osteoporosis specified, go with it. Age related is our default type of osteoporosis. And then we have the pubis ramus, which is 0.0A. So again, it's just more particular. So again, if you have a more particular bone, just don't go with the whole, well, we know it's part of the pelvis, so I'm going to call it pelvis. No, if we know it's actually, whether it be the superior ramus or the inferior ramus or the pubis, follow that in your alpha to get the correct code. Then osteoporosis. Right now for the pelvis, we have some stupid, I think we follow what, M80.08 or 5, or it's always a question. It's like, what do we actually use? Because there's just no direct shot to the pelvis. So now there finally is. So we've got the 80.0B, we have 1, 2, and a 9. So right pelvis, left pelvis, or unspecified pelvis. So that if you kick us a code with that 9 there for, we don't know the laterality, and look at that, it has no group assigned to it whatsoever, and that's your primary code, we're going to kick that back, right? Because it shouldn't be unspecified. Someone should be able to figure out which side do they hurt on, the right or the left. There's got to be an x-ray report somewhere, you would think, or even the physical therapist is going to note, hey, it's on the right side, it's on the left side. We know where it's broken. It's where the pain is. So when it comes to pelvis, there really should not be an issue with figuring out the laterality. And then we have the other osteos, with the 0.8 Bs. And again, that 9, no group assigned, not a good code. They used to call them, I think Lisa called it many years ago, the naughty 9s, back in ICD-9 day. 9s just don't get us anywhere financially. So yeah, I gave this one fireworks because I thought, yay, we finally have the pelvis defined for osteoporosis. Some SDOH codes, the social determinants of health. Anyone seen the cheat sheet, the Z code cheat sheet that I sent out just a little while ago? There's an SDOH section, and I already have it on my notes to rearrange them, get them in alphabetical order, the order you see them in. I think I just, I was just thinking, oh, we need that code, and that's how that landed. I didn't think, well, what do you say we get them in order of A, B, D? So they will be on the next iteration that comes out. So remember, when you're coding these, that you don't need anybody, you don't need any provider or anyone official like that to say that these are problems. This can come from documentation of a clinician. This can come from a family member saying something. We're getting a lot of these SDOH codes off of how the OASIS is answered, because we have particular OASIS questions that lead us to these codes, or at least these in particular that I have listed up here. So any codes assigned should reflect it's an actual problem, though, or risk that exists and will be addressed in the patient's treatment or their care plan. I know a lot of folks like to see, oh, the patient lives alone, I'm gonna assign Z 60.2 for patient lives alone. Well, all that's saying is the patient lives alone. You've got to show that somewhere, or someone has to show somewhere that because this patient lives alone, there is a problem in what is going on. They are unsafe, or they can't physically do something, and they don't have anyone there to help. So don't just use it just because someone lives alone. There has to be an associated problem with them living alone, and then you would use that code. Documentation, of course, in the clinical record should support that there is a problem or a risk. You know, and we'll see, it's like, for instance, the health literacy we have there, you're going to use it if the score is greater than or equal to 2, which is I think it's sometimes or something like that. So there should be in the nurse's care plan what they're going to do about, you know, working with the patient to be reading their medical stuff, so better understand how to take their medicines or whatever the issue is of their problem with reading their medical documentation, you know, the health literacy issues. These are just some others. These Z91s are all new codes that will come up, and they talk about the carers. You know, I never heard the term carer until I started watching a show that was produced in Australia. And they use the term carer, where we use caregivers, right? But they start talking about carers. I'm like, what in the heck is a carer? Well, now I know what a carer is. So when it came up in here, I'm like, well, isn't that interesting? Now we're talking about carers. So WHO, I don't know what their background is, but someone uses the term carer. So now we have all these carers. So caregivers. And it just has non-compliance, you know, and again, this is on the caregiver's part, non-compliance with things. So what is their issue going on? I mean, you could have a caregiver that's, you know, they're responsible for the patient and they're not doing what they're supposed to. So now we're moving into neglect. So you're hoping that there's a social worker involved in this case as well. We have some Code First additions that have come in. So I found this one interesting. The M97, the periprosthetic fracture codes. Right now, if you have a periprosthetic fracture and the joint itself, which is typically what they happen around, is depending on what's going on out in the case, you can put them in either order, whether it's, you know, the joint issue and then the periprosthetic fracture, or if the fracture is more important, you code it first. Not come October. Now it has a code first, where you're saying code first if known the specific type and cause of the fracture, such as traumatic or pathologic. So you have to put that first, and then the M97 code. It's like, okay. So now they're telling us, yeah, this is the order we want it in. So yeah, we've been watching your charts for a while, and you guys are all over the board. So we're just gonna set a directive. So you'll see if, and I know I've been seeing a lot of periprosthetic fractures coming up. People are falling. Population is aging, they're falling more, and we're getting more and more periprosthetic fractures because they have all these joints that are actually starting to age out and they're fracturing around them. We also have, currently, we have code first on the S22s, which is fractures of the ribs, sternum and thoracic spine. It says code first, any associated. It's changing to code also. So there is kind of taking away that specific code first. You have to do it this way. Now saying, go ahead and also add it on there somewhere. All right. And of course, always the if applicable applies. All right. Big slide. Looks like a whole lot going on just because it's, for whatever reason, it's big. The unspecified diagnosis additions. So see where it says unspecified part, unspecified part. Unspecified is never a good thing. You know, we don't want to be using unspecified. So this unspecified diagnosis means, yeah, we're not going to give you anything for them. You know, just don't waste your time. Give us something, lock into where it is. And here's what April was talking about. They've added hundreds of codes since W44, there's an X thrown in there somewhere, to some type of object entering via natural orifice. This is just like the ER went crazy. I think they just mailed in every single thing they have ever found and all their stories. And someone, I think, is still laughing peeing their pants about all this stuff going on. But like I said, if you ever just want to just be amazed at what goes on in this world, just look at the W44 section and just go crazy. All right, so I love sloths. It's my spirit animal. This is little baby Juno. She's a Cincinnati Zoo baby. Her mom's name is Lightning, which is hysterical for a sloth. The good news is Lightning was pregnant last year and Lightning had a stillbirth, and that would have been her first time. So when she got pregnant again this last season, we were praying she'd be good, and she had little Juno. We still don't know if Juno is a boy or a girl. Apparently it takes a while for you to turn down a sloth, and Juno's only about 3 months old right now. But if you look up the Cincinnati Zoo on Facebook, you can find Juno. And of course, my just absolute best are, BB and the whole hippo float there with Fiona and Fritz and Tucker. So I love my Cincinnati Zoo. So yeah, so that's all the codes. This obviously is recorded, so this will come up for anyone that missed or wants to hear all this again. And I will look up that whole emphysema thing and get that out to you one way or, it'll come out to you. So to have clarification and more information on that as well. Any questions at all?
I have a question on.
Yeah.
I was kind of looking at something. I was talking to somebody the other day, and somebody had said something about they were removing some of the adding the code for smoking from some of the respiratory. Did they do that, or was that just like something else?
I don't know. I'd have to, go through because you can find those under just about every single I code.
Yeah, exactly.
And I think you're right. I have heard that they're toning it down a bit, but I don't. There's nowhere that says all these codes have been removed from these following codes. It's just one of those you go
Gotcha.
through, and I just naturally add them regardless. I don't look at it and say, oh, you have COPD, so I'm gonna kill myself looking to see if you're a smoker. Well, you gotta find that they're a smoker anyway. So most of those conditions, I think we're just coding anyway, just because we're good coders, and it's not because the notes are telling us we have to.
Gotcha. Okay. Thank you.
But I think that's just kind of thing that we're just gonna